Hi, my name is Alison Inga, and I'm going to be talking to you about a practical approach to otitis externa. Let me tell you a little bit about myself. I went to vet school at St. George's University and finished my clinical training at the University of Georgia. From there, I went on to complete a small animal rotating internship at Red Bank Veterinary Hospital in New Jersey. After that point, I started working in general practice, where I started gaining interest in cases of otitis and dermatology in general. From there, I went on to complete a residency in dermatology and allergy, and now I'm a board-certified veterinary dermatologist. Otitis externa is one of the most common presenting complaints in veterinary medicine. It's also one of the most frustrating for practitioners and pet owners alike. Pet owners may bring their pets in with complaints of head shaking, scratching at their ears, rubbing their ears on the furniture, malodor, or because their pet seems to be in pain. When we look at these patients on physical exam, we may see changes to the ear, like swelling, redness, scaling, or crusting on the pinna. We may see exudate that's brown and waxy, purulent, or even serosanguinous. The canal may be erythematous, it may be ulcerated or painful. In some cases, you may notice cartilaginous changes to the canal, like early mineralization. In some cases, the ear canal may look grossly normal, and the only red flag that the patient may be uncomfortable is some patchy alopecia or broken hairs caudal to the pinna. It's important to look for neurologic abnormalities on our physical exam as well, as these can indicate otitis media or interna. These would be things like a head tilt, Horner syndrome, decreased or absent blink, or hemifacial spasm or even paralysis. Successful management of otitis starts with an understanding of otic anatomy and basic physiology. There are four major components of the ear, starting with the pinna, which is composed of auricular cartilages covered by hair on both sides. This leads into the external ear canal, which is lined by very smooth skin that has a thin epidermis and dermis with hair follicles, sebaceous glands, and ceruminous glands. The skin and its adnexa are continually exfoliating cells and producing cerumen. The canal ends at the tympanic membrane, which is a thin, semi-transparent, three-layered membrane. It's divided into two portions. Dorsally, we have the smaller part, which is the pars flaccida. And ventrally, we have the larger portion, which is the pars tensa. On the other side of the tympanic membrane, we have the middle ear, which includes the air-filled cavity called the tympanic bulla and the auditory ossicles. The bulla has a partial septum in dogs and a nearly complete septum dividing the bulla in cats. This is important when we have cases of otitis media or polyps in cats, because accessing them may be very difficult. It's important to remember that the facial canal housing the facial nerve runs through the middle ear, just caudodorsal to the auditory ossicles, leaving the nerve exposed in this area, which is also important in cases of otitis media. Finally, we have the inner ear, which includes the cochlea and the semicircular canals. And this area is housed in the petrous portion of the temporal bone. The healthy ear canal has a natural cleaning mechanism called epithelial migration, which clears away epithelial cells as well as any dirt and debris that may be trapped in ceruminous secretions. This key cleaning process may be disturbed in cases of otitis externa. There are four major factors that contribute to otitis externa. These are primary factors, secondary factors, predisposing factors, and perpetuating factors. Primary causes of otitis are things that cause disease in a normal ear. These are things like allergy, cutaneous adverse food reaction, atopic dermatitis, or flea allergy dermatitis. Autoimmune diseases like pemphigus foliaceus, cutaneous lupus, epidermolysis bullosa, or bullous pemphigoid. Immune-mediated diseases like drug reactions, juvenile cellulitis, which may have an adult onset as well, erythema multiforme, or vasculitis. Endocrine diseases like Cushing's disease, disorders of cornification like ichthyosis, or zinc or vitamin A responsive dermatoses, We can also have foreign bodies or parasites in the ears, like otodectes, chiggers, or ticks. There are also secondary causes of otitis externa, and these are things that cause disease in an abnormal ear. Things like bacteria, like rods and cocci, yeast and other fungi, medication reactions that can cause topical irritations, or even overcleaning that can cause tissue maceration in the ear canal. There are also predisposing factors. These are factors that are present prior to the otitis, but cannot cause otitis on their own. Things like conformation, including pendulous ears, stenotic or very hairy ear canals, excessive moisture and humidity in the ear, commonly seen with swimmers, or primary otitis media, like middle ear neoplasia, respiratory diseases, or primary secretory otitis media that we see in Cavaliers and other brachycephalic breeds. We can have obstruction in the canal like polyps and masses, or cystadenomas that we see in cats. Lastly, we have perpetuating factors. And these are factors that occur as a result of the otitis and make it more likely that there's going to be another infection. So excessive cerumen production, glandular hyperplasia, altered epithelial migration, edema and proliferation of the ear canal, and finally rupture of the tympanic membrane indicating otitis media. Now that we've discussed the anatomy and physiology of the ear, as well as the major factors that contribute to otitis, we can move into our diagnostics. Cytology is the #1 most important step in formulating a diagnosis and a treatment plan for patients with otitis externa. Once you've collected samples of exudate using cotton-tipped applicators from both ears, gently roll these samples out onto a glass slide. Heat fix it and stain them with a Romanowski type stain. Examine the slides under both low magnification as well as high oil immersion magnification. Make sure to take notes about the different types of microorganisms that are present as well as the burden, because this can vary very differently between left and right ears. Don't forget to take note of any inflammatory or potentially neoplastic cell populations. Keep in mind that some cases of otitis are aseptic. There can still be pain and inflammation without infection. The commonly found organisms on cytology are cocci, such as Staphylococcus, Streptococcus, or Enterococcus organisms, rods, such as Pseudomonas, E. coli, Klebsiella, Proteus, or Corynebacterium, yeast, like Malassezia or Candida, and finally mites, like Otodectes, Sarcoptes, or Demodex. Otoscopic evaluation should be performed in all cases of otitis externa. It's important to have a good otoscope with a bright light source. You'll also need various size specula to accommodate the ears of both dogs and cats. Your evaluation should include the status of the canal walls, including any pathologic or progressive changes to the canal, noting any masses or foreign bodies, the character of the exudate, any excessive hair, and finally the tympanic membrane, its color, opacity, or if it's ruptured or torn. You may need to postpone otoscopic evaluation in cases that have copious amounts of exudate in the ear, or patients that are painful, fearful, or aggressive. It's important that the canal be cleaned in order to evaluate it properly. So this may mean sending the patient home with a few days worth of oral glucocorticoids and pain medications, and having them come back at a later date for evaluation under sedation or general anesthesia. You may be wondering where culture and susceptibility come into play. This diagnostic test should be used as an adjunct to cytology. Be sure to include your cytology findings on your microbiology submission form. Culture is a very sensitive test, and it'll pick up any and all organisms that are present, including some that may not be contributing to the infection at hand. When you get your report back from the lab, compare that to your cytology findings and use that information to formulate your treatment plan, targeting only those organisms that are contributing to the infection. You should reach for culture and susceptibility in cases where bacterial infections are recurrent or not responsive to first-line antimicrobials, as well as cases that have already been exposed to multiple antimicrobials, and especially whenever otitis media or interna is present or even suspected. Cultures cannot identify yeast or mites, which is another reason that cytology is so important. You might miss these infections with cultures alone. Culture and susceptibility tests are intended to guide systemic treatment, not topical therapy. So keep in mind that drug concentrations in topical otic preparations are significantly higher than what we can achieve with systemic medications. Now that we've diagnosed otitis externa, it's time to come up with a treatment protocol. And this is generally going to include flushing and medicating the ear. At-home cleaning, meaning ear flushing, is indicated in most cases of otitis externa and is equally as important for maintenance of the ear canal post-infection. It's critically important for the ear canal to be clear of any debris in order for medication to contact the walls of the canal. This is because some medications can be deactivated by organic debris. So in some cases, we may need to have an initial cleaning done in the office, under sedation or even general anesthesia. You'll need to use your judgment when prescribing ear flushing at home for aggressive and painful patients. We certainly don't want to put our clients in harm's way. Some pet owners may feel more comfortable cleaning their pet's ears when using a basket muzzle. When prescribing at-home ear flushes, it's important for owners to have a basic understanding of the ear anatomy in order for them to feel comfortable cleaning the ears at home. I instruct clients to completely fill the ear with flush, massage it gently, and then wipe away any debris that comes up and out of the canal. I also send home a handout and a link to an instructional video. You can still flush an ear that has a ruptured tympanic membrane. You just need to be careful which cleaner you use, making sure that it's something that's safe to use in the middle ear. When it comes to the frequency of ear flushing, less can be more. In my practice, ear flushing is prescribed twice a week for most cases. I recommend flushing the ear 30 minutes before applying any medications on days that these need to be done together. Now that the ear canal is clean, it's time to use a topical treatment preparation. Topical treatment is indicated in most cases of otitis externa. It's important to communicate with clients that all medications and flushes come with some potential risk of ototoxicity. This risk is generally greater in patients that have a ruptured tympanic membrane or geriatric patients that may already be experiencing some age-related hearing loss. Our most common otic preparations combine an antibiotic, an antifungal, and an anti-inflammatory. The antibiotic most commonly used is the class called aminoglycosides. These cover some gram-positive and many gram-negative aerobes. This class of drugs works best in an alkaline environment. Next are the fluoroquinolones, which cover gram-negative bacilli and gram-positive cocci. Newer to the commercial market are the polymyxins, which cover mostly gram-negative organisms. And finally, we have the phenocols, which cover gram-positive, gram-negative, and anaerobes. Next, we have antifungals, which include most commonly the azole class of drugs, which includes miconazole, clotrimazole, and posaconazole. Antimicrobial stewardship is very important. Whenever there are just yeast on cytology, consider using a single agent antifungal. For me, I generally reach for miconazole 1% lotion when all I see is yeast on my cytology. The next most common class of antifungals that we see are the allylamines, including terbinafine. And finally, the polyenes, including nystatin. The last component of our otic medications is the anti-inflammatory, which is most commonly going to be a topical steroid. A recent study has shown that topical steroids can prevent the recurrence of otitis externa when used 1 to 2 times a week as a maintenance plan. I generally use mometasone for this purpose. We may also see DMSO, which is a non-steroidal anti-inflammatory that can potentially reduce fibroplasia, which leads to canal proliferation. Treatment frequency should be done 1 to 2 times a day for somewhere between 7 and 14 days for most uncomplicated cases of otitis externa. Complicated cases may require longer courses of treatment, upwards of 4 to 6 weeks. Treatment should always be continued until cytologic resolution has been reached. This is an often overlooked step, particularly in cases of chronic or recurrent otitis. Another tool that we can reach for are systemic medications, like oral antibiotics and oral antifungals, which may be indicated in cases where there's significant swelling or stenosis of the canal, and especially those canals that may be eroded or ulcerated. It's rarely indicated in uncomplicated cases of otitis externa, but it's definitely indicated in every case of otitis media and interna. We may need to use systemic medications in addition to leave-in treatments that are done in the office for patients that may be painful or aggressive. For these patients, we may also need to prescribe pain medications and anti-inflammatories. Glucocorticoids are my first choice for treating inflammation, including swelling and stenosis. You can use nonsteroidal anti-inflammatories in patients where glucocorticoids may be contraindicated. Don't forget to treat patients for pain, especially when their ear disease is chronic. In some cases, ear disease can be so severe that we have to turn to surgical interventions. And this procedure is called the total ear canal ablation, with or without bulla osteotomy. This procedure is a salvage procedure that should only be recommended to improve a patient's quality of life. Candidates for this procedure have what we call end-stage ears that have failed all treatment options, including rescue therapy with oral glucocorticoids and immunosuppressants. We need to set client expectations appropriately when recommending this surgical procedure. This surgical procedure does not cure atopy or any other factors that contribute to otitis. Clients will still need to be cleaning their patient's pinna at home, and their allergies are still going to need to be managed. Pinnal infections are still common, and postoperatively, the patient's hearing will be impaired. You may be wondering when it's time to refer to a dermatologist or a surgeon. A good rule of thumb is to refer to a dermatologist after 3 attempts to treat a problem. Exceptions to this rule would be cases that have multi-drug resistant infections present, when there's already canal mineralization, severe stenosis, or proliferative tissue present in the ear canal. Cases of otitis media interna, especially those that are already displaying neurologic signs, like a head tilt. Whenever there may be autoimmune diseases present. We should also refer whenever there's malignant neoplasia or benign middle ear polyps that need a ventral bulla osteotomy in order to access them. Anytime that there are perioral abscesses, or cases that may benefit from things like carbon dioxide laser ablation of proliferative tissues. Remember that any cases you suspect may need a total ear canal ablation with or without bulla osteotomy should be referred to a surgeon. If you have any questions or would like to know more, please leave a comment below. Please like and share this video, and be sure to follow this channel for more great content. Thanks for watching.